meandered into this space and weren't quite sure what it was about. The first thing I'll say is we have ASL interpretation, and also you can turn on captions at the bottom of the screen by clicking the three dots and hitting captions. Secondly, I'll say that these spaces are hosted by Interrupting Criminalization, an organization I co-founded with Mariam Kaba in 2018. And the goal was to assess, identify, and interrupt criminalization of Black women, girls, queer, and trans people in all aspects of life, certainly in policing and the criminal punishment system, but also in other systems like the family policing system, immigration enforcement system, and criminalization that happens in the context of access to healthcare. So in 2019, we came together a few times, and more at the end of the year at the Sister Song conference, to develop, to talk about how we might interrupt criminalization of many, many different populations who face criminalization when they seek healthcare, whether that's people living with HIV, people in the sex trades, migrants, disabled people, people seeking abortions, pregnant people, parents, and I think that was, and drug people who use drugs or are profiled as using drugs. And so we brought people together from all of those movements and organizers who are fighting criminalization, providers, people fighting for health justice, and came together to decide, what could we do to interrupt criminalization across all of these populations and sites, and decided to come up with a set of principles that we would invite providers and institutions and professions of healthcare providers to sign on to the principles and then implement them, not just sign something and then keep doing the same thing, but actually do something different. So we wrote them, drafted them, workshopped them with various groups and populations over the pandemic and beyond. And then when the Dobbs decision came down in June 2022, we decided it was time to publicly release them. We did that in November 22. And since then, we've been holding these monthly sessions to really explore what implementation of each principle looks like. In other words, going beyond saying, yes, of course, we don't agree with criminalization of people living with HIV or other infectious diseases, but to actually think about how that happens and what providers might be doing to facilitate that, or and what providers might be able to do to interrupt it. And so as you're gathering today, we're talking about principle number 9, which is that providers, healthcare institutions, and associations should stop participating in or supporting prosecution of transmission of infectious diseases, including HIV. And I think in this case in particular, it's important to point out that we're also talking about public health researchers and officials and workers in our kind of definition of healthcare providers broadly. So we'll spend the first hour talking with 3 people who come to this from 3 different angles, from a healthcare, health justice, HIV justice organizer, advocate, and anti-criminalization organizer. And there's so many other ways I could describe Kenyon Farrow, so I'll let Kenyon describe himself, but who is going to sort of talk about this overview of criminalization of infectious disease, including and beyond HIV. And then we'll be joined by Dr. Eisler, who is a healthcare provider here in Detroit, where I am located, who is actively involved in resisting the criminalization of people living with HIV and other infectious conditions. And then we'll close the panel portion of the first hour of tonight with Mandisa Moore O'Neill, who I have had the pleasure of knowing and learning from for decades, as has been the case for Kenyon, who is now the executive director of the Center for HIV Law and Policy. who will be talking about sort of policy approaches to interrupting criminalization of HIV and other infectious diseases. And so we'll be chatting until about 8 p.m. Eastern, 7 Central, 4 Pacific, no, 5 Pacific. And then we'll take a quick break, and then you all will break out into rooms based on either a group of folks that you came with, who you want to keep talking about these issues with, or a group of folks who share the same kind of role with you in the healthcare world. The nurses have a room, the public health workers have a room. I think doctors or medical students might have a room. We'll let you know what those rooms are after the break, and then folks can break into those rooms and really talk about how you can apply what we talked about in the first section in your day-to-day. So that's the kind of roadmap of where we are tonight. And I want to kick the conversation off with Kenyon, and I hope you'll describe and introduce yourself. But really, because Kenyon's the reason this principle is one of the principles, because one, because Kenyon has, taught us all so much about criminalization of HIV, but also because we were sitting at a table at that meeting at Sister Song, and Kenyon really laid out how criminalization, not just of HIV, but tuberculosis, of Hep C, of other, sexually transmitted infections, also contribute to the criminalization of migrants, of many other populations, and sits at many of the intersections that we were trying to address with the principles, and talk particularly about the need to go beyond criminalization of HIV to just criminalization of conditions, which, at the beginning of the COVID pandemic, I was like, oh, here's Kenyon, prophesying again, because here we are seeing criminalization, at least at the beginning of the pandemic, of a healthcare, of a health condition, but also because you had so many insights on like precisely how it happens. You were like, even if you don't believe in participating, you might inadvertently create evidence that could be used by someone else in a prosecution. And so just really, you are the reason this principle is on here and that it's as developed as it is. And so I'm going to turn it over to you to introduce yourself and kind of give us an overview of how you've seen healthcare providers contribute to this particular kind of criminalization.
Cool, thank you. Good evening, everybody. So you just heard, my name is Kenyon Farrow, he, him, his pronouns. I am in Cleveland, Ohio. So first I want to say that, when we think about, kind of criminalization of infectious disease, it's, something that is certainly not new. I think for a lot of people, particularly in the last 3 years, probably more people have become more conscious of it given kind of COVIDs, but we have a long sort of history of it, and it largely exists because infectious diseases, long before we kind of humans really understood them as viruses or bacteria or whatever, were often blamed on whoever kind of were marginalized groups of people, whether poor people, women or witches, as it were, to, Black and Indigenous folks, other folks of color, immigrants, et cetera, right? Just based on, whatever the sort of political desires to criminalize people at various points in history. So that exists, right? Secondly, when we think about the sort of birth of public health as a kind of, framework for understanding how, diseases, mortality, and morbidity impact populations of people, public health in and of itself has sort of embedded in it several kind of tenets that with that in some cases may be sort of acceptable kind of interventions or ways to sort of see things in a way, but in a kind of country and a world that uses sort of policing, surveillance, and these sort of tactics, like public health just kind of gets sort of moved along that trajectory, even if some of these tools didn't necessarily have that as the original intent. So when we think about, public health, we often talk about surveillance, right? Disease surveillance, right? Which is being able to kind of count, and monitor numbers of people who contract a particular infectious disease, right? So for just even in the kind of language of disease surveillance, is the sort of carceral state as we think about it. We definitely think about places of forced or coerced, kind of testing for disease. And then we think about the issues around contact tracing, of which we saw a lot of, certainly during COVID, which is a very old public health tactic of, when you discover someone has a particular infectious disease, you interview them and try to figure out who they've come into contact with so you can kind of map how the disease is spreading, which can be really important, especially in a what we call a kind of new and emerging infectious disease where you don't really understand kind of how it's being transmitted. And then we have, quarantine and isolation, right? And which sometimes happens forcibly so, right? So those are the kinds of things that, and those things are usually, kind of operationalized at the state level. I know throughout COVID, I see it a lot on social media. People are very angry with the CDC for lots of things, some of which are very valid. I think particularly in the wake of COVID, just their communication was so all over the place and has been and been very confusing for a lot of people. But a lot of the kind of implementation of public health programs or lack thereof of implementation lies at your state level. So I've been encouraging people in the last year, be more mad at your state if you see things kind of falling by the wayside in terms of, COVID measures, et cetera. CDC can make guidance, but ultimately it's up to the states, and CDC doesn't have much authority over what your state does or doesn't do, right? So that's a distinction I think people often miss. To the point Andrew made earlier, kind of in my introduction about, I won't get into HIV criminalization as much because I know Mandisa will cover a lot of the specifics there. But, we certainly have, again, histories of criminalizing infectious disease. I often use the case that people still use the term typhoid Mary to describe somebody who is coughing and wheezing and sick, which comes from a woman, Mary Mallon, who was an Irish immigrant living in New York City at the turn of the century, who contracted typhoid, and she contracted it several times. And typhoid is usually spread through water or food. And we certainly know New York City at the turn of the century, one might argue now, period, is a place, one, you have massive amounts of people, and you certainly did not have clean water infrastructure. You had raw sewage running through streets. You didn't have, you people touching food items, et cetera. And so she kept contracting typhoid, and she worked a lot in kitchens of rich people. And she was arrested several times and ultimately forcibly quarantined for many years through, kind of, her picture was put in the papers, et cetera, right? So, we have this example of ways in which an individual, based at the time, particularly on a lot of anti-Irish, sentiments, got sort of targeted, right? But we also see it in terms of, modern day, really starting in the early 1980s with HIV, with Mandisa will talk more about. But we've seen it also in other kind of infectious disease areas. In a lot of cases, many states have laws that criminalize the intentional either non-disclosure of an infectious disease, whether it's HIV, viral hepatitis, tuberculosis in some cases, some other STIs can be used or fall under those laws. So either non-disclosure, exposure, or intentional transmission, right? And so you see a lot of these cases, particularly with HIV in the press, where the first sort of news story is, a person is on the loose, quote unquote, is how it's often framed. and it's spreading HIV to all these unbeknownst, people. But often when you get to the actual stories and lives of those individuals, it's far from anything, so kind of, maniacal. So there are those things. Now, part of what Andrea mentioned is a few years ago, before COVID happened, through my work, kind of working on, HIV, TB, viral hepatitis, I started to notice on a lot of right-wing blogs, like Breitbart and et cetera. So this is in the Obama era, where they were beginning to use in a lot of the kind of anti-immigration sentiment, tuberculosis as a particular kind of infectious disease, which, similar to COVID, is airborne, right? It's an airborne, but a bacteria. And so you were seeing a lot of these like blog posts that were saying, well, we don't want these immigrants coming across the border because, they're going to spread tuberculosis all over the place, et cetera. So that was already being kind of operationalized. And so it was and I, as Andrea pointed out, I was like trying to scream at people. This is part of how they're using the kind of anti-immigrant sentiment around the borders, is they're using this infectious disease as a strategy to sort of get people, riled up and to be less, have less empathy for folks who were trying to enter the United States. And then that just, kind of went, tenfold, certainly during COVID. And I'll say lastly, before I turn it over, in terms of ways in which we also see this, play out either in other infectious diseases, and the way, sometimes providers play a role in the dynamics. So, you also see stories pretty regularly of a person with hepatitis or with HIV who spit at a police officer. The stories happen all the time, where people are then charged with, intent to expose somebody to hepatitis B or C, et cetera. You see that quite a bit. And the way providers sort of play a role in this kind of happens at a couple different sort of sites. So one is, particularly for HIV, in most states, and in states where they have existing criminal laws on the books, when a person is diagnosed with HIV, in a lot of states, people have to, the first thing after you're told that you have HIV, which, despite having, really incredible medications in this day and age that keep people alive and also keep people from also spreading the virus, if they're successful on treatment, the first thing people have to do is sign a piece of paper saying, that you're HIV positive, and you know that the laws of this state, this is here in Ohio too, are such that if you don't tell your, sexual partners or whomever that you're living with HIV, you can be, kind of brought up on X amount of criminal charges with X amount of, years in prison potentially served. So that's like the first thing people have to do, right? And it is, that happens in, both in public health clinics and health departments, but it also happens in doctors' offices, right? As well. And I know that before for instance, like North Carolina a few years ago reformed their, kind of HIV criminalization laws. And I know that there were some efforts being made by activists in North Carolina to get doctors, particularly in the larger cities in North Carolina, who were in neighborhoods where they were more likely to test people for and diagnose people living with HIV, to get doctors to actually just not give that paperwork out to people. And so, this kind of becomes one way. And then the other piece of it is, and we can talk about this more in the Q&A perhaps, but more and more our kind of public health systems and our healthcare systems kind of data is shared across institutions, right? So when a person gets diagnosed now with HIV, their information is both their physicians or their clinics, have that information, but so do the county health departments, right? And so there's this interplay between your provider and the public health infrastructure. And in some cases, particularly this happens a lot in Mississippi, Human Rights Watch wrote a pretty extensive report on this about 10 years ago in Mississippi, where health departments have what they call disease intervention specialists, who were basically getting notices from doctors' offices or whatever that this person tested positive. And so this disease intervention specialist would show up at your door. And in some cases, we're telling people and threatening people in the Human Rights Watch report that so you're living with HIV and this is your husband, fiance, wife, partner, etc. And if you don't tell them, I will, and I will take you to jail for non-disclosure. Like, these are the kinds of things that happen. And so there's this interplay between kind of public health data, private electronic medical records, and the carceral state, right, in terms of the way some of these things play out. So I'll close there and pass it on to my other panelists, and we can have some more discussion later. Thank you.
Thank you, Kenyon. Someone did ask if you know what happens if someone refuses to sign that paperwork.
That's a good question. I am not a lawyer, so
I am, but I was hoping you would know the answer.
Mandisa might know the answer to that question too. So.
All right, Mandisa, you can, when you come around, if you could let us know. But I just want to really lift up this piece that you're saying, Kenyon, about even things that seem innocuous or beneficial in the context of a carceral state, in the swimming of an environment of policing, turn into something that has someone at your door threatening you with arrest, right? And so it may seem completely, consistent with care and with the oath that providers took to say, yes, sign this piece of paper. It gives you lots of information about your diagnosis, including acknowledging that you have it, and it's a good idea to tell people whatever, you think you're doing a good thing, but we're swimming in a sea of carcerality that then, and then because of electronic health records and so on, you might not be the sheriff at the door. You might not even have sent the sheriff to the door. You might not even know that's happening, but that's a consequence of what's happening in your office. So yeah, thank you so much for setting that up. I'm now going to turn to Dr. Eisler, who is a healthcare provider here in Detroit, who works with folks who are diagnosed with infectious diseases. And there have been a few new ones recently, monkeypox, a few others that you and I have talked about. Tell us how you've seen, as someone, and who's also caring for criminalized populations, queer and trans folks, particularly, how you've seen healthcare providers both contribute to the kind of criminalization that Kenyon described and also resist it.
Hi, everyone. Thanks so much for having me. So I actually am the medical director of the STD clinic in Detroit. And so I do STI work and HIV work. So it's really interesting, kind of going off what Kenyon was saying. So it's really state-based. So Michigan is one of the 13 states that HIV is decriminalized. And so I have been really kind of fortunate in that, like, actually having patients that were like really being prosecuted for non-disclosure, for example, I really hadn't faced until a recent experience with a patient who I diagnosed with HIV like 3 years ago, a young Black gay man who wasn't even out, and he had a whole 3 years of coming out. It was this big deal. He even came out with his status on Instagram. And he was living in Ohio. And I don't think much of it. And then he comes just for his regular follow-up visit, and he's like this quiet guy. He's just like, he likes to just like game. Like, he's like not doing anything. And he's like, yeah, like I didn't take my meds for 2 weeks because I was in jail. And I was like, oh, what were you in jail for? And he was like, basically he met this guy on Jacked or, whatever app. And on those apps, there's a place to put your status. And he said it was on, I don't know. They had oral sex. And after the partner asked him, do you have HIV? He said, yes. Mind you, he's been undetectable for like 3 years. And after that, the guy pressed charges in Ohio. And so after this, when he tells me this, and again, I'm not a lawyer. I don't know any of this. This is so new to me. He's facing felony charges. So what I did, and so many of the providers I work with have never experienced this. So I called and he is so new to the system, has no idea what's going on. I called his public defender, and just one of the main dilemmas that I think, first of all, we're not even following the science, which is also like, it's already messed up, right? Like how exactly we're criminalizing all these tuberculosis and all this. And now with HIV, it's like, this is undetectable equals untransmittable, with amazing science to back it up. And so I called the public defender's office, and I said I would go on the stand. I wrote a whole letter for him to bring to the judge. And so I think that there is this room for physicians who have this like power with an MD behind my name to do this. And now this trial is that we still don't know, because it keeps on getting like postponed, or I don't know the term in lawyer talk, but so we don't know what's going on with that. I think something that, so I think one dilemma we have is that there's different stuff state to state. So it's like patients are moving state, like, and they don't know this change in laws. And that causes a lot of issues. I think one thing that I really appreciated what Kenyon was saying. So we have, talking about these DIS workers, disease intervention specialists, like they are truly in the infectious disease and communicable disease world. They're the backbone of the system. And it's problematic. Like it is this dilemma. And how do we, when you're trying to stop, I would say my mission is to stop the HIV and STI epidemic that disproportionately affects Black and brown people, in particular, men having sex with men and transgender women. And so when you have this awful disparity, stopping the transmission is essential. So, but how do you do this in a way that isn't perpetuating reporting and kind of, doing incarceration in this public health realm, which I find, we have a DIS worker that doesn't work. He works in our clinic, but he's, employee of the state, which I am not. And like, I think one of the big things is creating relationships with these state workers that they start kind of, I'm reporting, right? A new syphilis case, you have to report it, but how do we do it in a way that isn't stigmatizing and is actually just getting people their health and not making them feel gross or dirty or like a leper? But I think it is this complicated thing that we struggle with when we're talking about communicable diseases. And we see a big disparity in HIV and STIs. Yeah, I think that's kind of the main stuff that I'm kind of battling with.
I mean, I really appreciate naming this kind of interstate issue, because I think with electronic health records, which Kenyon mentioned, also like everything travels. So what you write or do in one legal environment lands in another legal environment, right? And so I think that's an awareness that, we might have on kind of a theoretical level, but then, as you're saying, this very practical thing where then it really comes, home in a particular way is important people to really think about. But really, how is this going to land? How is what I'm writing going to land? How is what I put in the chart going to land? How is this paperwork I'm creating going to land that might just be routine for here, but is going to land differently over there? And then I think this piece that you're saying about building a relationship with the folks, in the carceral sea, who could join the carceral wave or pull out of it with you, right? And how do you grab them and be like, listen, we're not banging on anyone's door. We're not threatening them with arrest. That's not good for healthcare. That's not good for everyone's well-being. We all care about populations who are disproportionately impacted by both poverty and, every other stressor, including criminalization. We're not doing this. We're not going to participate in this. But that requires like a lot of relationship building. And as you're saying, even if they work in your office, you're not supervising. They're employed by someone else. So it requires doctors to take time to do, which, y'all don't have a lot of time to like build those relationships. So I think that's really feels important. And this question of, how do we navigate this in a non-stigmatizing way? And then how can you show up? I mean, you could have just been like, wow, that sucks. I'm sorry that happened to you. Let's get you back on your meds. And instead kind of took the initiative to really step in and see how you could interrupt. So I think that's kind of three things for providers to really think about, and the dilemmas that you're facing around, like, but I have to report it. It's required. I have to do something. Is there any way to avoid reporting things, I guess, is maybe the question.
But I think it is really interesting because reporting, right? Like, when we have definitely seen, like, partner services in particular, which in the state of Michigan, which I found quite interesting, is way more intense for syphilis than for HIV, which is interesting. And I think that there may be, because of the stigma of HIV, I think that's kind of been the way to combat it, is like they kind of like hold back. But it is this thing like partner services. There is a really helpful thing to have people's partners anonymously told so they can go test for HIV and syphilis and get treated. And I think, like, how do we really navigate these kind of public health concerns and this criminalization that, it's, as Kenyon said, is like built within that world? How do you not like care about public health but not perpetuate this, which I find to be at times hard, in that, like, I don't know the right way, right? Like, besides the fact that I have to report it, I just really work, this one DIS worker that I work with who has all my cases. It's like, I fully trust that he is doing this in a way that is thoughtful and is really there for those partners, because, like, yeah, then they can get help. And if they don't know about it, then they can't get treated and tested. And so I think that there's kind of sometimes opposing things that are hard to navigate.
Right, because the ethical requirement is to do no harm, but there's a few people involved here.
Exactly.
All right, thanks. We'll come back to find out more about how you might be organizing with other folks to do that, or how you might invite other physicians into thinking about this collectively. But I'm gonna bring it to Mandisa to talk about how we change this legal environment a little bit, and then also answer our legal questions about, well, what if you just don't sign the thing?
Great, all of the legal questions.
That's right. But also, please just introduce yourself and let us know who you are, in addition to being the ED of the CHLP.
Hey, y'all. I'm Mandisa Moore O'Neill. My pronouns are she, her, hers. I'm based in New Orleans, where it is a motherfucking sauna down here, y'all. Woo, it is hot. And I lead a national organization, CHLP, and we work around. So first, I want to just say, at CHLP, it's really important, like, as far as to use affirming and dignifying language. And so when possible, our language, well, not when possible, all times, our language is people living with HIV, as opposed to an HIV positive person, or, you know, somebody infected with HIV. And the reason why is it's important to use person first language. Very simply put, these are principles that people living with HIV said. This is how I would like to be called. I'm a human before I have HIV. Something else that we are experimenting with at CHLP is saying HIV and other stigmatized health conditions, as opposed to infectious or communicable. So we're trying it out, seeing how it lands, open to y'all's feedback about how stigmatized health condition lands. For us, it's also a way to acknowledge those health conditions might change as the political climate that we're in changes. And so stigmatize is a way to acknowledge that, like, now it's HIV, viral hep, but who's to say, like, Mpox, of course, was that. So it's a way to do that. But what we do is at the federal and state level, work with state coalitions, health departments, some federal stakeholders around addressing the criminalization of HIV. As was said, first of all, I love how many of my points Kenyon and Shira touched on. So I just love that. I'm like going through, knocking things off, but it really is a state issue. But there are guidelines at the federal level that are important, like HHS, CDC, ONAP, Office of National AIDS Policy, that can have an input on what states do. For example, many folks, well, I don't know many, but perhaps folks have heard of the Ryan White program. It is the largest healthcare program for people living with HIV in the nation. It is the payor of a last resort. It's how many people access health services, supportive services, all of these things. When it was first passed in the early 90s, the Ryan White Care Act actually had a clause that in order for each state to receive the funds to implement Ryan White at the state level, each state had to ensure they had a mechanism for prosecuting people who intentionally transmitted HIV. So again, even though this is really a state issue, there are ways, like the federal government has incentivized. And so I would argue you incentivize states as far as to have these laws on the books in order to get funding. You then have a duty to incentivize these same states to modernize these laws in ways that acknowledge what HIV is. And so far, the federal government has been like, no, we don't. So it's a great conversation happening at the federal level on this. But thinking of like one large issue is talking about what criminalization is. So as we talk about it, folks think of it as the person living with HIV who's accused and the person who accused them. And maybe folks are thinking of the court system. And as Shira, had the example, that is how some people are criminalized. And as Kenyon also mentioned, many people are coming into contact with law enforcement. That's how they're being, criminalized. So for example, it is very common for a state to have a clause, like to have a statute. I'll give example of my home state, Louisiana, which actually had a criminal law 4 years before Ryan White. And it's always had this very, very vague clause called means in contact, which courts have interpreted to include spit and saliva, things that first day of epidemiology class, folks will say is not a means of transmission. But because means in contact is so broad, there are people who've been prosecuted and are still serving time based on they spit on an officer. So unfortunately, that is something that is happening in other states where there's no sex involved. There's no sexual contact. It's in the context, of resisting arrest. And as a former defense attorney, I would have to say, if I'm being arrested, what action on my part is not seen as resisting arrest? If you're arresting me and I won't be arrested, anything I do will be framed as resisting arrest. So let's just talk about what that actually means. Like, we often hear these phrases and we automatically think, oh, that person hit a police officer, that person did something. No, sometimes asking why am I arrested is enough for law enforcement to frame it as that person has resisted arrest. So let's just keep that in mind in terms of power dynamics and who gets to frame an issue a certain way. And outside of folks who are coming in contact with law enforcement, it is a common incident for a law enforcement officer to subpoena a health department and for a health department to voluntarily share that information. So a huge part of what we're seeing at CHLP is not only the importance of working with coalitions who are working to modernize these state laws, and also working with at the federal level, but also working with health departments and training them on this is not an example of a mandatory reporting situation. 2, just because somebody subpoenas something does not mean that you are obligated to share it. So I don't know if there's anybody on this call who lives in Nevada, but they have a really amazing health department there, and the legal team there has a system in which the whole health department knows if any law enforcement agent, if that state troopers, if that sheriff's office come forward and have a subpoena, it goes to this body. And their first question is to fight it. Is to question, why do you need it? Is to make them show you, is there no other way of you getting this information but for this disclosure from this health department? Oftentimes, how we see it happen in other states is, unfortunately, everyone has been socialized that when a cop asks you a question, what do? You answer, you comply. It includes health departments. So that's an area like that we're seeing where there are many ways to intervene in terms of training public health department legal teams around how to fight a subpoena, is one area. The other thing, and I appreciate this, is being clear expansively as to how we're defining a provider. So for me, in my work, it includes case managers, it includes social workers. Those are also folks who are coming in contact with people living with HIV, via the Ryan White program and other programs. And again, is this an example? I remember prior to being in my role, I worked in legal aid and had to work very, very hard with the case manager to convince her not to call the cops on her client, because it was a person who was newly diagnosed, and her role is to get people into care. Now, how is it that if your role is to get people into care that you call the cops? That's another conversation, but it is a red flag for me as to how are you doing your job if you're calling the cops. But her reason why is the person was excited about going on a date. All the person said is, I'm excited, I'm going on a date, I'm going to look cute, da, 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 da. That was enough for her to say, oh, they're going on a date, they're going to have sex, and because they're newly diagnosed, they still have a detectable viral load. And she felt so justified. And it took a while to be like, you've made a lot of leaps here. Like, you've made so many leaps here. All you know is the person is going on a date. Number one. Number two, have you had any questions about safer sex tools? To even assume that if the person's having sex and all of these things. And unfortunately, I would like to say that that is an isolated incident. Unfortunately, that's not the case. It's very common in which people take it upon themselves, like to make a decision about someone else in a way that then has a huge impact. Quickly, just to answer the question, I think Kenyon answered it as far as pregnant people who aren't in care, or perhaps are in care and have a viral load. It isn't as common, and there are still cases of that person being criminalized. And the reason why is most states' laws don't actually have a requirement of transmission or even an intent to transmit. Most state laws actually focus on exposure. So in that situation, there are hundreds of people who didn't even transmit HIV, let alone if they engaged in an activity that could have transmitted. All you have to show is that there was an exposure, which is very broad. And, it's important to say, it's important to focus on what's the specific intent here? Most of these laws don't even have anything about intent. You knew your status. You did something that if you weren't living with HIV wouldn't be criminalized in the same way. That's enough. Which, side note, that really undermines a lot of the public health goals, because often what happens is if knowing your status is enough to be on the hook and potentially criminalized, what's the incentive of knowing your status? So it actually works against public health in that, it's all these campaigns about being empowered, about knowing your status, all of that. But then how are these laws actually working against what public health workers are trying to do when they technically able to?
The other question was, can you refuse to sign the form, Mandisa?
So you can do anything, and some of the consequences of that, it depends on the state. Some, it could be a fine. It's also possible to get like a court order, like to supersede. It's been, unfortunately, some situations where if I'm somebody who's living with HIV, thinking of the racialized framework, like in the ableist framework of how we talk about HIV, and I have refused to sign this form, that could be seen as mentally unfit. So a court order is then used to be like, oh, this person can't even make a quote unquote simple sort of decision to sign a form. I will go around and mandate them. And unfortunately, it is instances in which someone is arrested. But here's the reality of it. They don't even have to do all of that. So many people, all they have to do is rely on the stigma that people, like stigma of HIV, and that does so much of the work for people. So it hardly gets to a place in which folks are not signing because like the stigma and shame that we as a society have put on HIV does the work of people, oh, I'll sign in a minute because I'm ashamed of this thing that I have. So I want to be clear that those are examples and those do happen. And we're talking about a stigmatized health condition here, which means that it plays out in a lot more subtle ways. So in the interest of time, I will stop. I thought there's some more questions.
I think at this point there's mostly comments, but I think
Okay.
And then I want to come back around and ask people how, if there's sort of broader campaigns folks can join. But I think two things. What you're saying is that the other thing that comes into play with people signing these things is it's your healthcare provider who's asking you to sign it. And your healthcare provider is not giving you like a Miranda warning when you sign it, right? They have delivered news to you that's life-changing and overwhelming. And then they're like, here's some information and sign right here. And I'm like, well, you're my healthcare provider and you're supposed to have my number one interest at hand. So I'm going to trust you to sign it. And you're not telling me this can be used against me in a criminal prosecution later. And I'm just wondering what for us all to kind of think about how we do that without adding to the terror of that moment and etc. So just to
one more point. Is that okay? 1 minute?
Can you hold it for the next round?
Yes.
Okay. Because I think the other thing I want to name is the thing that you were saying about criminalization, which is that in the case of people trading sex, in some states, just existing as someone who trades sex without even any exposure takes a form of a different kind of criminalization. You might be criminalized for trading sex, but then put on the sex offender registry because you're HIV positive. And that is completely unrelated to exposure. It is related to kind of being part of a criminalized population. So I want to name that for folks, particularly who are working with folks who are in the sex trade, that's a possibility in their state. But I want to come back to you, Kenyon, to ask sort of, are there things that folks can get involved in on a kind of campaign level or collective level to shift some of the ways that what you and Dr. Eisler have talked about is like valid public health needs and desires and concerns, right, around transmission, around protecting larger populations, et cetera? How can we address those needs without pulling in the carceral piece of it. And I know that you and I, in the COVID context, tried to think, and many other people tried to think about, like, what could contact tracing look like that's not criminalizing, right? And some of those suggestions are in this report that are in the chat, but are there ways to do these things that are not criminalizing that folks can kind of get involved in trying to push for?
Yeah, so I'll talk about like some official campaigns, and I'll talk first about some just informal things I think people can do or just think about. So one of the concerns that I have right now with, like, a lot of, kind of when, COVID happened, a lot of, kind of radicals started to kind of focus and talk about COVID and infectious disease, and, in some good ways and in some ways that were, I think, very unhelpful. And so much as I certainly get and certainly have been very much leading a lot of the critiques of the government response, to COVID in a lot of ways. However, I think kind of some tendencies that I've seen on, kind of social media and some other places through some individuals is actually almost, and people who I think would call themselves abolitionists, who in their kind of frustration with like the sort of government failure and frustration with people, kind of deciding that they're gonna, not get vaccinated or not wear masks or do any of the other sort of, kind of protective, almost are calling for things to me that go against 40 years of work that, HIV activists have done around harm reduction, and understanding that, like, trying to force people and coerce people to take whatever kind of public health measure you think, whether it's wearing condoms, whether it's disclosing your status, whether or in the COVID sense, these other things, that we are walking a very dangerous line, I think, of actually kind of co-signing on a lot of the worst instincts of like the kind of carceral state and public health measures at the same time. And so I would really ask people to really, like, if you're unfamiliar with like harm reduction as a framework, or with a lot of the work that people have done around, kind of harm reduction as it pertains to, safety around whether it's, kind of sex or around drug use, et cetera, as a way to think about how you actually can engage people, meet folks where they are, and build the kinds of relationships with folks where then you can, have some discussion about what people might be able to do that is more kind of safe in that sense. So that's kind of a, more of a kind of an individual thing, and not as much a campaign. The other thing I would say is, and, again, Mandisa, and, we been doing this for a while, so sorry, I don't want to steal your thunder, but I know Center for HIV Law and Policy and, Zero Project and some other organizations have been, the Positive Women's Network and a few others have really been leading a charge around an issue which is called molecular surveillance, right? And so what molecular surveillance is, molecular surveillance is essentially the technology that we have, which is how we understand how viruses are mutating, right? This is including COVID, right? It's part of how we understand variants, right? Is to be able to test samples of, blood or other bodily fluids and kind of understand the sort of, genetic makeup of a virus to be able to see transmissions, right? And so when a person is diagnosed with HIV, and one of the first, sort of things that happens in when they get a blood draw is to determine what's called resistance testing, right? So to determine if there's any medications that are on the market that they have that their particular virus has a resistance to, so that the provider knows not to prescribe them that medication and to get them on a regimen that will work better. That technology has been around for almost 40 years. But in the last roughly 10 years or so, CDC started to use that technology, not just as a way to help people determine what medications will be best, what treatment is best for them in terms of HIV, but to actually use that technology to try to understand at the population level dynamics of transmission, right? And which has freaked a lot of people out. And it did me too the first time I learned about this, because given the ways in which, as Mandisa pointed out, prosecutors already subpoena records of people living with HIV in order to sort of prosecute these non-disclosure or exposure cases or what have you, what happens in a situation where a prosecutor tries to subpoena records to determine whether two people have a similar enough strain of the virus or not to be able to make a relationship about transmission. Now, the technology does not exist at this point to determine whether this person, contracted HIV from this other person, right? The technology can't tell you that. But we know prosecutors don't give a shit about the truth, right? Like, and if they could make they could be admissible in a court situation where they make a determination that this particular virus, that because they're in the same network, that the likelihood is there, right? Because they have a similar a genotype of the virus. So Center for HIV Law, so that's a long way to say that, like, Center for HIV Law and Policy, Mandisa's organization, and some other ones have been doing a lot of work to get the CDC to put a moratorium on using molecular surveillance in this context as a kind of epidemiological tool, and to be more transparent about explaining specifically how the technology is used. When people go for treatment and get blood, they're not really giving consent to use it for those other purposes, right? Like, so this becomes another kind of ethical problem. And again, as Mandisa pointed out, a lot of the work that, I think she and I kind of agree with, that kind of sits in the HIV space because it still has a particular kind of political and social, cultural charge and stigma in our society. But nothing is to say that another infectious disease later would not have these same kind of dynamics. And so I would tell people to look at the Center for HIV Law and Policy's website, and where there's lots of great information about ways to get involved on that particular issue, as it pertains to molecular surveillance and, HIV.
Thank you. And I just appreciate what you were saying about, like, abolitionists need to be careful no matter where we are, right? Like, that the scarier the thing is, the bigger the thing is, the more it's disproportionately impacting Black communities, the more the people who are causing the problem are like the prison guards who are bringing COVID into prisons where people can't get away from them and can't social distance and can't mask. And, the more we're like, maybe somebody should put a charge on that prison guard or something, right? Like, we have to stay aligned with our values. And I think that's part of what we were trying to do with those contact tracing principles, is to say, can we imagine a way of meeting the public health needs, or in this case of meeting kind of whatever benefits there are to molecular surveillance in terms of surveilling evolutions of viruses or whatever, while really putting kind of a barrier down on carceral uses or surveillance-based uses. So it's a challenge, and one that we'll continue to look to your leadership and thinking to help us figure out. I'm curious, well, first, Dr. Eisler, I wanted to share with you, I need to drop this off at your house eventually, but share with you something that was inspired by you, actually. It was you and I were talking about something completely different one day, and I happened to mention this network and this work, and you said, well, plug me in. And I said something like, well, we have these webinars like this, et cetera, et cetera. And I got the sense from you that you were like, listen, I run a clinic and I got kids and I don't have time to be coming to webinars in the evening, but just plug me in. And so based on that conversation, we came up with this pod kit, which is basically, I'm going to hand it to you, and it's just like something that you can use to have conversations with the people you're already talking to in your practice, in your community, in your medical association, the people you always have drinks with at the conference. So you don't have to go out and reach anyone new. You don't have to go anywhere new. You don't have to talk to anyone different. You don't have to come to a webinar. You can just take this pod kit and, you know, figure out, first of all, we have a little recipe book in here so y'all can cook dinner together, and then you can decide what you want to talk about based on what's in the kit. You can take notes in this beautiful notebook that was hand stamped by Hoyan. If you tell each other a great story, like you just told us about resisting criminalization, you can also tell it to our storytelling project, or you all could sit around and listen to someone else's story and talk about it. And then we made you some cool pins that you can wear around the associations, the conferences, your office, and then you can recognize each other as providers who are engaged in this work. So I wanted to share that because there are many ways that folks can get involved. And so how you get that kit is you tell us that you want one, and that you have 5 people that you'll at least have one conversation with about how to interrupt criminalization, you know, in the next couple months. And that's how you get it. So I'm gonna drop yours off, Dr. Eisler, but I just want to let you know that that whole idea was inspired by our conversation. And so I am curious, as someone who's, you know, running a clinic, very busy, and very active in this work, how you see providers could plug in to interrupting criminalization in the way that you've been doing or that we've been talking about tonight.
Well, first of all, love that kit idea. Thank you. And I will be all about that pin. I think I think it's actually understand kind of in abolitionist work. It's like there's a lack of, for the layperson, understanding, hey, how does Jim Crow come to policing now, right? Like there's a big lack of understanding in that connection. And I think it's the same with HIV criminalization. And I think just as we were saying before, which I think was really great, like it isn't just the case that I brought up with a court case, but like being in touch with law enforcement and, you know, this spitting and like even just my case, that was oral sex. If you look on the CDC, it is negligible risk of oral sex. So I think that like it is actually like getting providers to know that this is happening. I don't think most providers in the HIV world know. I feel like one thing is like there's like my medical world and then there's my activist world. And they are like, they're not meeting each other. And I think that is kind of maybe, I would consider maybe that would be a role of mine is like, you know, I'm on faculty at Wayne State University. I'm giving lectures all the time. This is a place that I could, that you can use your role in power to break down these systems of power. And that's like kind of where I think like these webinars are so awesome. And like, it's really like hearing Kenyon, like that's a great resource for me to hear, okay, this guy's right in Ohio. That's a great contact of getting those type of people who into the medical world. And I think like just having this conversation with providers I think it would be eye-opening in wild ways.
Thank you so much. And for naming the fact that so many providers are also teachers, right? And so just so that this is the goal, right? Is that we're now sending people who are providers on this call the tools to have a conversation with your fellow providers over a meal or just over coffee or just over whatever dumb administrative task you're all stuck doing at the end of the day, to just raise these issues and see what people say and see what they do and see what people.
And I just want to say one thing is that like in the infectious disease world, in the HIV STI world, there's this big thing right now with syndemics, right? So like STIs and HIV, they're coming together and we can't look at them in silos. And I think that like, and now this is like a very well acceptable kind of understanding of this, in that like we can now use that with HIV and criminalization, that these things are actually together. And they're in the fact that this HIV disproportionately affects Black and brown people, and so does the criminal system. Like this isn't like a coincidence, right? And so I think that like putting these things all together as also another syndemic is also like using kind of these medical terms would, I think, really help like spread the word and really be kind of change the paradigm.
That's a brilliant idea. Thank you so much. And just thanks so much for being here. And folks are really excited to think about the education platform. And so that could be something else that if you come up with kind of a lecture that where you bring those things together for your students, and it's something that you want to share with other people in the network, we'd be happy to help do that or whatever. So I think the idea for providers is whatever you're already doing, if you're finding ways to bring this into conversation, then just share with us and we'll share it back out to folks so that folks can...
Happy to do that. And now I am inspired by this and I'm planning to make this my next lecture.
Awesome. Thank you. Mission accomplished. All right. Go forth. Mandisa, I'm sorry to have cut you off before. Please tell us what you were going to say before, and then also anything you have to add about how folks can plug into this work. And can I just ask, as you're saying that, can you explain what modernization of these laws means? Because I think that worries me sometimes, not about what you're doing, but about the language, because it's like, I don't want to modernize laws that criminalize people. I want to get rid of them. So what are we talking about?
First of all, cut me off and don't apologize. Like, you have a whole thing that you're doing. I'm just talking. So first of all, thank you for that. Something like that we're seeing at CHOP is the importance of not just doing a repeal. And here's what I mean. In some situations, folks have organized, have done like dope ass shit and have repealed their criminal statutes. And it didn't actually stop prosecutions in that state because most of the times, even if there isn't an HIV criminal statute, folks are still criminalized under general criminal statutes is one thing. So one of the things like that I've been talking about with our team, and a huge part of our work is to actually bill draft with a coalition. Like, not everyone can afford a bill drafter. We can do it for you, with you. Is as a strategy, what would it look like to simultaneously propose a repeal and make it harder to prosecute under general criminal law? And so I'm not torn. I mean, I'm not like fixed on a modernization, because I do agree. I'm trying to end the prosecutions, but trying to think of a word that's making it clear that sometimes it's not just going to be a repeal, because then, like in Texas and Illinois, folks are just prosecuted under the general criminal statutes. That's one thing. The thing that I was going to say earlier is thinking of providers. Something that happens a lot is doctors, nurses, NPs, case managers are called on to testify. That's a really clear way in which you can fight that. And instead, what you can be is a medical expert for someone who is defending themselves. So that's a huge part of what we do at CHOP as well, is when folks unfortunately are, are facing a charge, working with that person and their team to help find medical experts who can come in and testify, about that specific case, about, and this is a true story, finger vaginal penetration in Ohio is not a means of transmission. So that's something that I would also look into as far as ways of supporting people. And the last thing I would say is I want us to be really mindful of what it means to craft policy around undetectable equals untransmittable. I think it is amazing individual legal strategy. I think it is something that is very helpful. And if used to craft broad-based public policy, it actually helps to contribute to what many folks have called the viral divide. I think it's all sorts of reasons why people are compliant with medications and are never going to have an undetectable status. And so if we're saying those who are undetectable shouldn't be prosecuted, unfortunately, what we're then saying is those who do have a detectable, viral load for any reason should be prosecuted. And again, that's not always our intent, but it is something to be mindful of, especially looking at the ways that detectability often falls along racial and class lines. So just want to keep that in mind in terms of that. Last thing is, I'm going to drop a link in the chat. We have a source book in which we go through all 50 states and the colonies, Guam and Puerto Rico, and we look at the laws and write 5 or 6 pages about them, so you don't have to be on Google and spend your time. And we update it about every year and a half. So it was last updated in February 2022. It is currently being updated now, soon to be released, likely, if I'm being honest, early 2024. But it's a source book and it's great. You have the option of clicking on your state. It'll tell you if your state has a criminal statute. If it doesn't, some example of cases, super helpful.
Amazing. And anything that keeps me from having to read a law is welcome. All right. Can everybody please, I say that as a lawyer who doesn't like reading laws. If everybody could please give it up for these 3 brilliant panelists for sharing their experience, their analysis, their resistance, their inspiration, and their resources with us. Just, throw some emojis up, throw some claps in the chat, share your reflections, and then we are going to go into the breakouts. So I'm going to turn it over to my colleague Maria Thomas, who coordinates the Beyond Do No Harm network, without whom none of this would be happening, including these beautiful podcasts that were also made by Hoyan, who's DJ and tech master extraordinaire today. So I want to thank them and our ASL team and captioner, and turn over to Maria to put us into pods based on profession, based on who you came with, or other things. Take it away, Maria. Thanks again, Kenyon, Shira, Dr. Eisler, and Mandisa. Lovely to have you here and be in conversation always.
Thank you all, and we can stop recording at this point. So Hoya,